I would like to formally welcome you for this extremely informational webinar. And our topic is breast cancer, early detection screening, treatment modalities, where we are going to focus on ER/PR, HER2, and triple negative breast cancer, the surgical considerations, and survivorship. So before we invite our speakers, I would just like to give a brief about who we are, what Breast Cancer Hub is, so that you just learn a little bit about why we are doing this and the mission and purpose of our organization. So BCH, I'm Dr. Lopamudra, I'm the founder and president. And BCH is a GuideStar Platinum certified 2021 top-rated 501c3 nonprofit registered in North Carolina, but we work globally. Our mission is to help make sustainable changes working at the grassroots level by bridging the gap between the developed and the developing countries. BCH focuses on breast cancer in women, men, and all genders and supports all types of cancers through our mission of awareness, education, research, community outreaches, screening camps, and we kind of take accountability, like everyone has our contact information, anyone can reach out to us, and then we try to navigate them towards the healthcare resources, where if it's underprivileged sector, we try to take them towards the hospitals, serving with the subsidized treatment. It's basically kind of like taking care end to end. We also have support groups which are localized, and we have a very private WhatsApp group. Globally, we are connected emotionally, though we are different parts of the world, we kind of share, like we live like a family over there. So, and we do a lot of counseling. I do one-on-one with the scientific counseling, and in our support groups, we have oncologists, we have nurses, we have the survivors, and their words come as magical, because when a survivor is talking to a patient, nothing better than that gives the strength. And that's why survivorship is so important. And we have two amazing speakers today who are going to talk after our distinguished other speakers deliver their speech. So we all have also adopted villages. We go door to door based on the breast cancer screening, and also try to focus on other types of cancers. And we kind of like when we are doing the door to door the screenings, we basically take care of the screening, diagnosis, and treatment management, because the villages is very difficult with the financial situation. We try to take care even of the financial treatment aid. Now our revenue is very low, so we can't take care of like the patient treatment wholly for one person also, but we try to do in bits and pieces, because in the underserved areas, even to get the diagnosis, it needs money like 10,000, 20,000 rupees, which is like $200, $300 per person we can afford. But we may help with the treatment scenario, like with the diagnosis part, and after that the government aid comes in. So we help with the income certificate and all of that, so that we know that these patients are getting treated. So that's how we collaborate with the local hospitals. We have now adopted 11 villages in southern Assam, and we collaborated with the Kachar Cancer Hospital, and we also take the patients to Silchar Medical College, where it's very much subsidized treatment is available. So that's how we are trying to, go door to door and help with the scenario. And apart from that, this is like a whole, like this is how we are working, but all our services are free of cost. I do everything pro bono and full-time voluntary. And everyone in the USA, we are all volunteers. So it's kind of like we do not have any government aid, but we are so grateful to our community because of their kind-hearted donations. They're able to sustain Breast Cancer Hub. So that's who we are. And I'm so honored today to have on our panel distinguished, the speakers, and we would like to invite our first speaker, Dr. Geetha Manjunath, who is the founder and CEO of Niramai Health India. Over to you, Geetha, and we, Dr. Geetha, and we look forward to your talk today. Thank you.
Thank you so much, Dr. Lopa. It's a real service that you're doing. One, by connecting all the people of common interest in driving away breast cancer deaths, if I can say that. And of course, you yourself, are doing so much of service from an NGO standpoint. Really hats off to you and the whole team here. So thanks for giving me an opportunity to sort of talk about an innovation that Niramai, which is a startup based in India, is doing. And I'm the founder and CEO of Niramai. So this is what we call as thermalytics. And in the next 10 to 15 minutes, I'm going to sort of quickly talk about this innovation and love to hear comments from the panelists and the audience. This statistics is definitely known to all of us here. Last year we saw more than 680,000 deaths due to breast cancer alone as a primary cause. And what is unfortunate is that the survival rate in India is just still about 50 to 60%. That is, every alternate lady detected with breast cancer is dying. How can we reduce this? We can reduce this if there is a systematic screening or at least early detection program that is put together. And I'm very happy to hear that a few villages have been adopted and we're trying to do this. But what happens is today in India or countries like India, most of them, more than 60% of the ladies appear in stage 3 or stage 4. Why? What are the gaps in the current screening methods? First, of course, is the awareness. And some of these programs will really help in creating the awareness so that people know that breast health is as important or more important than anything else for their family, because their health is their family's health as well. Additionally, there are some technological limitations and economic limitations that today deters people from doing a regular mammogram. Definitely not possible. Annual mammogram is definitely not possible in countries like India, where there's huge population and as economic viability is an issue. Apart from the affordability and accessibility issue, current method like mammogram or screening mammogram has very low sensitivity in women under 45 years of age because of dense tissue. The first one you're seeing is a fatty tissue of a 60-year-old, and the second is a 40-year-old, which is fully dense, and it's very difficult to sometimes see even a big lesion here. And dense breasts are seen on almost 50% of women, even above 45 years of age. So this is a big issue. Also because in India and countries like India, or Asia particularly, the mean age or the peak age for breast cancer is around 50 years, which means almost half of the patients are under 50 and may have more than that, may have dense breasts. So this is a big issue, even if you enable a very affordable way of doing this with mammogram or such techniques. And of course, ultrasound has its own limitations because of subjectivity and so on. So in this scheme of things, Niramai, which is our startup, which we founded up about 4.5 years ago, we have developed a new method, which is called thermal analytics. We just measure temperature variations of cells using a thermal sensor, which is an infrared imaging device that we see for COVID screening in many, many places today. A little high resolution thermal imaging device measures about 400,000 temperature points per person, right? So what you're seeing here is a heat map of the temperature. So white is highest temperature, red is next, and so on. And this temperature variations of every tissue, right, very accurate temperature value of each tissue is analyzed using a smart intelligence software that we have developed using artificial intelligence to say whether there is a probability of malignancy in the person. If so, where, which breast and which clock position is it likely to be? And this can be done automatically by a health worker. And this is possible because of the patented software that called Thermalytics, which has actually resulted in 25 international patents today. So the advantages of this is that it is non-contact, non-invasive. Nobody sees the person or touches the person during screening itself. Of course, non-contact is a very, very beautiful thing because there's no pain, no compression. But no-see is a major thing for adoption. They just it's like a changing room. Like the lady enters, she has to disrobe on top, but not even the technician is seeing her without the top, right? It's because there is a screen, the technician is one side, and the screening is done on the other side. Absolutely no radiation, we just measure temperature. It does work on women of under 45 or above 45. Yes, it works on men too, right? Male breast cancer is also an issue. And it's, I'm happy that BCS is also taking care of that. And most importantly, it is much, much more affordable, less than 1/15 the cost of a mammography machine. And it is a portable device, just 1 liter water bottle size, which can either be performed inside a hospital or taken out to do camps. Yes, it is ready. We have done about 40,000 women screening so far. And it is deployed in 70 plus hospitals, such as Apollo Clinic, HCG, and top hospitals here. And you see here, like there's a small booth, the lady is inside, actually screening is happening, and the technician is outside. Very small compartment is created. This is actually in a corporate office that we did. And we've done several camps, outreach camps, and one of them is in this bus. But we don't need a bus all the time. This is a Rotary funded bus to a hospital called Sakrawad Hospital, and it's actually screening around a lot of people in and around Bangalore. And because of COVID, a lot of even urban women were stuck at home. So we started private screening at home using this technique. And as you can see, a lot of rural camps and at different district hospitals, referral hospitals, free camps have been conducted by Niramai team. I'm just going to play a 30-second video to just give you the experience.
Did the Niramai technology to me. Having heard about it, I went to get a checkup done. I was quite skeptical before I went for the test. It took me by surprise because the machines didn't touch me. It was all happening from far away. जैसे eye test होते हैं ना, दूर से बिल्कुल वैसा.
It's a very, very simple test, as you can see.
Did the Niramai.
And the key thing here is that not the thermal imaging, because thermal imaging has been around for some time and it has been used and misused multiple ways. What we do is to take the thermal temperature, not just look at the image. We take these temperature values and spin it through this AI wheel, if you will, to actually generate a report automatically. And I'll be very happy to go through more details of it. But just because we have clinical audience, I just want to share that, yes, it does work. We have high sensitivity as well as high specificity with, we have fine-tuned for highest cancer detection. So screening sensitivity is today 100% with asymptomatic screenings also, and just about 7.6 false positive rate. And this is actually published in ASCO JCO. When we compare with mammography, and if you see the orange bar, which is cis screening population, actually mammogram misses many, many cancers because of dense breast. And in this case, you see two women with dense breast, and you see how the thermolytics output looks like, right? Here it's very clear that it's cancer, and here it's also very clear that it is not cancer. So this is also a technique that can work really well on dense breast, as you can see in another study. There are many such studies we have done, and I'm happy to collaborate with all of you to actually take this solution to many, many women. And it's also regulatory cleared, not just in India, and also in Europe, Africa, and Asian countries. A lot of good testimonials. And the key advantage, just to summarize, is that having an accurate way of detecting early stage cancer, of course, late stage as well, and doing it at a cost of almost a self-list examination, slightly higher than that, is what this enables. And in addition to that, it's a no touch, no pain, no see, no radiation. And it does work on women of all age groups. 2 billion women who are about 25 need to be screened at least once in 2 years. And today, just less than 10% of them globally are being screened. And we really need to address this 90% of the women by solving the current gaps in early screening. Before I end, I also want to just flash this one. In addition to the thermolytics-based screening, we have really, thanks to, because of the October month, we've actually released a breast health helpline. This is a WhatsApp number. Anyone can actually send a hi message and ask a question, and we answer them within a few minutes. And this is, of course, free. In addition, using the same WhatsApp number or an online form that we have, they can actually put in a few, like 10 to 12 questions they can answer, and we give a breast health assessment using machine learning and proven AI technique as well. So I encourage, please, all of you to, announce this and share this with others, because it's a free service just for the health of women in the world today. Thank you so much. And, we are at your service to help technology helping saving lives. Thank you so much, Lopaji, for the time, and happy to answer questions whenever there is.
Thank you so much, Dr. Geetha. That was so amazing. So I really wanted everyone to learn about the thermolytics, and that's why I'm really excited that you presented. And we can, probably many collaborations will come up from here, and everyone will learn about, there's so many, I know because I talk about mammogram and the dense breast concerns, because here in the US, we are now more emphasizing on the 3D mammogram or tomosynthesis. And in addition, we suggest that if you have dense breast, we go for ultrasound. But in India, kind of like we still do not have in all healthcare facilities the 3D mammogram. So it's a mammogram. Then in addition that, we suggest with ultrasound. And of course, like, if women want, they can go for the thermolytics. And equally, as you said, like breast cancer in men, we like with BCH, we are equally focusing on both and also in all genders. So it's applicable for everyone. So that's really
Absolutely.
informative. And thank you so much.
Thank you so much. And this is being used instead of mammography in many of the hospitals, even in Apollo.
Absolutely,
so,
yes. So that's wonderful. That's wonderful. So thank you so much for sharing your presentation and about Niramai and what amazing work you all are doing. We are honored to have you here.
Thanks.
So, thank you. Our next speaker is Dr. Gourangie Gogoi. She is the Associate Professor of Department of Community Medicine at Assam Medical College and Hospital at Dibrugarh. Over to you, Dr. Gogoi. And I'm going to share your screen so that you can start with your presentation. I hope you can see the screen, right? Dr. Gogoi, if you can unmute yourself.
Yes, thank you, Dr. Lopa. Sorry for all the trouble. Actually, network suddenly it collapsed. So
no problem.
I'm joining in with my speaking on. Yeah, I shall be speaking on role of screening in early detection of breast cancer. And I'm so happy to have listened into the previous speaker's presentation on thermography. And so you can move on to the next slide, Dr. Lopa.
Yes.
So why breast cancer screening? So breast cancer is the leading cause of cancer death in women worldwide and main cause of cancer-related death in women in developing countries. And what is here is that where many have advanced disease at presentation, they go undetected. And from among the developed countries, it is the second leading cause of cancer death in women. Next slide. So now, what is breast cancer? So we say that it is the medical screening of asymptomatic, that is when there are no symptoms and the women are apparently healthy, with the goal of achieving an early diagnosis should disease be detected. Next slide. So what are the options available for breast cancer screening? First is the breast self-exam, then clinical breast exam, breast ultrasonography, breast MRI, mammogram, breast tomosynthesis, that is the 3D mammography that you were talking about. Then now more latest technology where they do a contrast enhanced digital mammography. And of course, to avoid the radiation after effects or adverse effects, we are now going towards thermography, which is the more preferred method of breast cancer screening. Next slide. So for any screening program, we fall back on WHO's 10 principles of screening, because these principles have been taken, or they are the guidelines for almost all the organizations who have developed their own screening guidelines for breast cancer. So first of all, the condition sought should be an important health problem. So in my first two slides itself, I have given you that it is the second leading cause in the developed countries and the leading cause among cancers in the developing countries. So it is an important health problem. And there should be an accepted treatment for patients with recognized disease. So we do know that breast cancer is entirely treatable provided we get the diagnosis early. And facilities for diagnosis and treatment should be available. There should be a recognizable latent or early symptomatic stage, so which then gives better results. And there should be a suitable test or examination. Next slide. The test should be acceptable to the population. So whatever screening test we develop, no doubt they could be very sensitive, but the population should accept that test. Then the natural history of the condition. When it is a long drawn or non-communicable disease, then it becomes more feasible for putting to the screening test, because then we can follow up the whole natural history, including the development from the latent to the declared disease. And that should be adequately understood. That should be really clear that when it starts, how it progresses, and what is the prognosis. And there should be an agreed policy on whom to treat as patients. Next slide. The cost of case finding, including diagnosis and treatment of patients diagnosed, should be economically balanced in relation to the possible expenditure on medical care as a whole. This is especially in context of our where we are resource constrained in the developing countries. And case finding should be a continuing process. It's not at once and for all that we are doing some health camp, we are locating, identifying the cases and forgetting about them. So it should be an ongoing, the screening process entirely should be an ongoing thing. So these guidelines have been taken from WHO, from the benefits and harms of mammography screening. Next slide. So organizations now, these most of you, because you have so many years of working experience with breast cancer, you do know them. So these are the list of organizations who have formulated guidelines for breast cancer screening. Next slide. So what we do for breast cancer is that before putting the women through the screening, we always evaluate for the risk factors, because risk factors have been already identified or proven to be very important in the context of breast cancer. So some personal history we take, especially age, ethnicity, age at menarche, age at menopause, age at first pregnancy or has not given birth, obesity, especially weight gain after menopause. Next slide. And then long-term hormone therapy, especially if it is more than 5 years after menopause, alcohol use, smoking, prior radiation exposure, number of breast biopsies, and also previous atypical ductal hyperplasia or atypical lobular hyperplasia, then latent, lobular carcinoma in situ or ductal carcinoma in situ diagnosis. Then of course, breast density, which is again, if the breasts are more dense, then it becomes very difficult through the screening procedures to identify any carcinomas. Next slide. Then we come to family history also, because as you know, the gene mutations, they have again been proven time and again about the degree of relationship, then early onset cancers, male breast cancer, then ovarian cancers, they're linked with the family history. Then next slide. So most of the organizations, we have seen that they have categorized the women into 40 to 49 years with average risk, 50 to 74 years with average risk, 75 or older with average risk, and special one category for women with dense breasts. Next slide. And some organizations have released different breast cancer screening guidelines for women who are considered to be at high risk. So those previous slide, I talked about average risk. So most of the organizations have identified women with high risk, which have risk factors such as BRCA1 or BRCA2 mutations. Next slide. Who have a history of chest radiations which occurred before the age of 30 years, and who have a lifetime breast cancer risk of 20% or greater based on their family history, who are untested family members of someone who has BRCA1 or BRCA2 mutation. Next slide. So NCCN have they have put up guidelines for genetic counseling and referral, and these are the exhaustive list of guidelines for genetic counseling referrals. Patients with personal history of breast cancer diagnosed younger than 50 years, triple negative breast cancer diagnosed at less than 60 years, personal history of 2 breast cancer diagnoses regardless of age of onset, known mutations of a cancer susceptibility gene, then multiple close family members with related cancers, whether breast, ovarian, colon, endometrial, etc. Diagnosis of ovarian cancer, diagnosis of breast cancer in men, and some Jewish descent line which have a personal history because of the genetic component of, because they're again a secluded your social group. Next slide. So then again, when we talk about breast cancer, we must not forget about the risk factors in men. Those who are getting older, those who have genetic mutations, family history of breast cancer, radiation therapy, hormone therapy, Klinefelter syndrome, which have an extra X chromosome, liver disease, overweight and obesity, and also certain conditions that affect the testicles. These are the identified risk factors for men. Next slide. So many studies have been undertaken in about breast cancer screening. And here I have put up some salient findings of these studies. First, it says that attending regular mammography screening can potentially increase early detection to improve treatment outcomes. And also regular mammography attendance is suggested to reduce breast cancer mortality rate by up to 40%. Next slide. And health educational programs that create breast cancer awareness are effective in increasing health promoting behaviors such as breast self-examination. Following an educational video, one study has found that women's susceptibility and perceived self-efficacy of breast self-examination and perceived benefits of mammography have increased. Next slide. And there is also a perceptible link between breast awareness, breast self-examination awareness, and screening uptake. And we must also remember that we should be talking about healthy breast, because once screening is done, once it is detected, then obviously treatment is the next line of next procedure. But what we need to focus on is to maintain a healthy breast. It's about the lifestyle changes, and it's about obesity control, and it's about diet. So that we must not forget. And because most of the the overall sensitivity, so to say, of mammography is about 80%. Then the remaining 20% which are not detected by mammography are detected by clinical symptoms such as palpable mass or suspicious nipple discharge. And there are, as in any screening test, there are false negatives as well as false positives. False negatives are more likely with lobular carcinomas that tend to grow along the normal breast architecture. Next slide. For women who are 40 to 74 years, who undergo screening every 1 to 2 years, breast cancer mortality is reduced by 40%. And false positives occur in about 10% of screened women, 80% of which will be resolved by additional imaging and 10% with breast biopsy. And one important limitation of screening is the false negatives. Next slide. The technological advances which were spoken by my previous speaker also, that is about digital breast tomosynthesis and breast ultrasonography and magnetic resonance imaging. So these are very important for dense breasts. And most national screening guidelines suggest that there is value in mammography screening for women who are in their 40s. And of course, but still it must be an informed personal choice for women in their early 40s, which is widely supported. And annual screening for women 45 to 54 years of age, for those who are 55 years or older, should then transition to biennial screening. Next slide. Breast cancer awareness interventions are important to increase the uptake of breast self-examination behaviors and increase the likelihood of breast cancer screening attendance. Survivability and general morbidity and mortality outcome measurement is a challenge because of the shortage of suitably evaluated campaigns. Next slide. There are many benefits of mammography screening. First, I talked about the reduction of breast cancer related deaths. Most of the RCTs which were conducted, they have shown a relative reduction vary between 15 to 25%. And meta-analysis of some observational studies have given estimates of 13 to 17% reduction of breast cancer related deaths. And there is the reduction in costs associated with treatment, which is less invasive in early stages. Next slide. And there is the better prognostic indicator, because we can always go for breast conservative surgery instead of mastectomy. There could be a decreased need of chemotherapy, less time off work, and decreased likelihood of axillary lymph node metastasis, fewer axillary lymph node dissections, and then reduced lymphedema. Next slide. Deterrents to mammography are some of these, first of all, overdiagnosis and overtreatment, then anxiety, mental health issues, mammography itself being a radiation exposure, then as I said, false positives, false negatives, and what screening interval to maintain, that is always a query. Next slide. So we have a situation where we could have early diagnosis, but then maybe there may not be a correct mode of treatment, or maybe the diagnosis gave an extra anxiety. So there is always need to be a balance between how to make a diagnosis of the breast cancer through screening, and whether we have really given more anxiety by giving a false positive result. So this needs to be really focused on, and the informed choice, next slide, informed and shared decision making in this screening process is very important, because then the beneficiary must have the best knowledge about the options of the best screening options, and about the benefits and risks of screening, and decide with the healthcare provider whether the screening, which screening is right for that person, and if so, when to have it. And again, I must reiterate that the focus must be on the breast health through diet and lifestyle approach. That is, that should be the focus in any screening program. Next slide. So currently, no widely accepted view of supplemental screening of women with dense breasts has been reached, even though the sensitivity of screening mammography is recognized to be reduced in such women, because there have been no randomized control trial which have determined any mortality benefit from supplemental screening. Next slide. So there are certain challenges in our developing countries, because most of the population depends on a deficient public health system, and there is the delay in diagnosis due to lack of awareness and screening opportunities. The indicators observed in developed countries sometimes cannot be directly compared with those observed in our developing countries. So next are my few of the slides of my references. That's all. Thank you so much for patient hearing.
Thank you so much, Dr. Gogoi. That was really great, speaking about all the different pros and cons of the screening processes and bringing everything together, also mentioning about the key risk factors. That was really great. So thank you so much for your talk today. I just want to add up a little bit over here that, like we have, as you mentioned about the breast self exam. So we have developed the breast self exam card, for both men and women, and in collaboration with Sarah Cannon Cancer Institute and Male Breast Cancer Coalition. And we have it in 24 languages, because that's the disparity, right? We cannot go towards because of so many concerns in the developing countries, especially in India, when I thought of starting, BCH and going to the villages. So that was the purpose of having it in local languages. For example, when I'm going to Chennai, I'm giving it out in Tamil. When I'm in Hyderabad, in Urdu and Telugu. When I'm in Assam, I'm giving it out in Assamese, Bengali, Hindi. So that really works very well, because it's a one-stop place and it's for both men and women. and it's a very simple language. So I will put the link in the chat box. Please download in your network and download and share in your network. And then of course, like when you feel any abnormalities, you should start checking your breast from the age of 17 or 18 years old. So like the reason is that basically the fundamentals is to observe if any abnormality, to observe the look and feel of a breast to detect any abnormality. So once a month. So this is kind of like, it may lead to false positive or false negative, but at least, you're monitoring your breast, because most of the screening is after 40, the mammogram, but younger women are getting breast cancer, young men are getting. So this kind of acts as a tool where we use our fingers to detect, and also all the signs and symptoms are written here. So please download and share, and this kind of becomes a life savior too. So because many women in our support group itself, they got detected because of breast self-exam. And thank you so much, Dr. Gogoi, for bringing out all the perspectives. It was really, really helpful, especially the statistics and everything. So thank you. So this was all about the screening opportunities that we have with the breast cancer scenario. Now we will go to the next part. Like, once detected, what do we do, right? It comes as a shock because, there are so many receptor status, the tumor grade. So everything is like, for someone who is not acquainted to cancer scenario, it becomes a huge turmoil. So that's why we try to simplify and bring it to you, and what are the different options. And we couldn't think of, like, we are so grateful here to have Dr. Deba Sarma, who is the breast surgical oncologist at Atrium Health at the Levine Cancer Institute in USA. So over to you, Dr. Deba, and we are looking forward to hearing about the hormone positive and the HER2 receptor status and the surgical considerations with breast cancer scenario. Thank you.
Well, thank you. It's definitely a privilege and honor. So thank you for inviting me to be part of this panel today. I'm just going to share my screen.
Yes, we can see your screen, Dr. Deba. If you can make it full screen, that would be great, if possible.
Is that full screen now?
Yes, it is. It is.
Okay, perfect. So let me just. Okay, so again, thank you very much. It is definitely a privilege. So what I thought I would do, as a breast surgical oncologist, I really want to just spend the next sort of 10, 15 minutes to kind of discuss the surgical considerations that we make when it comes to breast cancer treatment. And as Dr. Lopez already, mentioned, anyone can imagine when a woman comes in with a diagnosis of breast cancer, it's extremely emotional. It's a very trying time. Emotions are just running rampant. And, as a breast surgeon, we're typically the first people that women see when they're initially diagnosed with a breast cancer. And so, I don't see uncommonly when a woman comes in, they say, you know what, I understand I have breast cancer. I understand it might be small, it might be in only one part of my breast, but, I need you to be aggressive. I want a double mastectomy. Do whatever it takes as aggressively as possible because, it's all about survival, of course. And so as part of my job, what I see it is, it's not really just to explain that, no, it's just, maybe you only need a lumpectomy. Maybe we only need to remove 2 or 3 lymph nodes. And that's probably all you need. But what's really, I think, important and definitely a large part of my job is that patients need to understand why. Why is it that we're making such recommendations? And that I think it's, important for them to understand that a lot of the surgical recommendations, even the medical oncology and radiation oncology recommendations, are just based on science. We have a lot of data to back up why we do what we do. And I think it's important for us to be able to convey that to the patient. And it's also really important for patients to understand that breast cancer is a very multidisciplinary treatment approach. So, I don't want to delve too much into statistics, and this is definitely pertaining to the United States, but I did want to drive, some key points. While the incidence of breast cancer has been shown to actually be increasing, what is definitely very important to note is that in the US alone, there are over 3.8 million breast cancer survivors. And a lot of this has been related to the widespread, implementation of screening, early detection. So we're seeing some decline in mortality, at least in the United States, So of course, the overall goal is that we want to increase breast cancer survivorship. And out of this, even 3.8 million, at least 150,000 are actually living with metastatic breast cancer. So it's not just about, employing surgical techniques, the multidisciplinary approach to get people to the best quality of life with breast cancer treatment and survivorship and beyond. So again, this is just, alluding to the multidisciplinary approach to breast cancer care. And this is just, a few of the players that are intimately involved in breast cancer treatment. So now to again go back to sort of the whys. Why is it that we do what we do? I thought I'd just go over a little bit about the evolution of breast cancer treatment from a surgical standpoint. So here is just a picture of William Halsted, who was a very prominent surgeon at Hopkins in the 1890s to the late 1840s and 90s. And and so before the 15th century, what was happening is, a woman would present with very local breast cancers. Sorry, Dr. Lopa, I know you said you want me to start my video. Let me do that. Okay, sorry. Okay, so, a woman would come.
Actually, the request came from Hiren and Usha Sarma.
Oh, sorry. Okay. So again, before the 15th century, a woman came in with very aggressive, locally advanced breast cancer. But therapy was really futile. It was just, trying local ointments. The idea of systemic therapy was really more related to what we call purging and bloodletting. And as you can imagine, that was not very successful. In the 1500s to 1700s, there was a much more improved understanding of the local spread of breast cancer to lymph nodes and then ultimately to the rest of the body. And it was felt that surgery was probably critical in trying to attempt to stop that. However, this is before the advent of general anesthesia. So again, as you can imagine, surgery was extremely morbid due to the lack of anesthesia. Now we come around to the 1840s where general anesthesia was starting to become utilized. And again, this is a picture of Dr. William Halsted, who really revolutionized breast cancer care at that time. And his theory, again, and his understanding was that breast cancer did spread locally into the lymph nodes, the regional lymph nodes, which are in the axilla, the armpit region, maybe above the collarbone. And he thought also it spread via the muscle itself before it then went on to what we call systemic spread or spread to the rest of the body. So he revolutionized what's called the Halsted mastectomy. And here's the pictures of the Halsted mastectomy. And what this really involved was removal of the entire breast tissue, removal of the underlying muscle, what's called the pectoralis muscle, removing as many regional lymph nodes in the armpit, below the clavicle, above the collarbone. And as you can see here, this was an extremely morbid, deforming, debilitating surgery. Very painful. There was not much attention paid because, again, the thought was be as aggressive as possible. So not much attention paid to preserving nerve structures. So a lot of these women were rendered paralyzed, and again, with significant deformity. So one thing that Dr. Halsted did do, as in many other surgeons around his era, was actually chronicle a lot of the research and a lot of the findings after this radical operation, which was, again, the start of very important clinical trials related to breast cancer and surgery. And what was starting to be understood in the early 1900s, sure, that surgeons were doing the most radical operation. And while there was in some women a curative value, there were still women coming in maybe months later, 1 to 2 years later, who then came in with distant disease that was in the bone, the liver, the lungs, and so forth. And of course, this threw surgeons for a wrench. They said, we did the most aggressive thing that we could possibly do. How is it possible that cancer was coming back? And this is now where we were starting to understand that clearly breast cancer is more than just a surgical disease. There's a lot more involved, and it's more what we call biologic and systemic. And this is where there started becoming a better understanding that there must be maybe chemotherapy, endocrine therapy, anti-estrogen therapy that is very important in the treatment of breast cancer. Along came with, in the 1970s now was screening mammograms. This was becoming much more prevalent. So now women were not just coming in with very advanced disease, but smaller cancers were being detected. And again, there was much more improved understanding of tumor biology and the role of chemotherapy and radiation that can actually play into the treatment of breast cancer. And even more importantly, was now increased public awareness. So in 1970s, 1980s, if you go back, you'll see a lot of campaigns sort of talking a lot more about self-awareness in the Western countries. This here is a picture of Dr. Bernard Fisher, who is really now heralded as sort of, becoming very important in how we do what we do in terms of breast surgery. So he really revolutionized a lot of the landmark clinical trials in breast surgery. He was a very prominent surgeon, recently passed away, and he was at the University of Pittsburgh. And he started questioning, again, with understanding that this is much more biology, much more systemic disease, is really aggressive surgery all that much better? And so he started questioning that. And again, going back to the fact that the Halsted mastectomy was extremely debilitating, very, very morbid, he started questioning, can we do less? And he started doing what was called the modified radical mastectomy. And instead of removing the pectoralis muscle, which again was the deforming, most painful part of the surgery, he questioned, can we just remove the breast tissue? Can we remove some of the lymph nodes and start employing things like radiation therapy? And is that good enough? And the answer is yes, absolutely, it's good enough. And there's actually been 25-year follow-up studies that have shown that instead of just doing what's called the radical mastectomy, we can modify it and really improve quality of life without impacting survival, because that's the key. If you're going to do less surgery, if you're going to do what's called de-escalation of care, survival cannot be negatively impacted, and that's what he had proven with the modified radical mastectomy. Then, of course, Dr. Fisher and many other surgeons decided to continue to push the envelope. Can we do more? Can we actually even do less surgery than we were doing? And the answer then became absolutely yes. So again, with now better understanding of radiation techniques and medical management, he started questioning, can we just remove the tumor with what we call negative margins, leave the rest of the breast alone, hence called breast conservation, employ radiation and achieve the same survivability as if you were to do a modified radical mastectomy? And again, the answer was yes, and has been validated in 20-year survival studies showing that there is no difference in overall survival when you compare breast conservation, because you add radiation, to mastectomy. And it is important to also, sort of drive the point that lumpectomy alone doesn't achieve the same risk of same survivability. So lumpectomy with radiation does significantly lower the risk of local recurrence and then ultimately overall survival. So the goal of breast conservation is really to minimize extensive surgery and its associated risks and morbidity. It does minimize the risk of local recurrence when you add the radiation therapy. Of course, the ultimate goal is also to achieve acceptable cosmetic results and maximize quality of life. So then as we go through the decades, now we come into the 1980s, where there continues to be much more advancement in treatment, and goes back again to tumor biology. Tumor biology plays an extremely important role in determining the best treatment modality. And even as a surgeon, I have to say it is not all about the surgery. So in the 1980s, we have the introduction of what's called adjuvant hormonal therapy, and neoadjuvant chemotherapy was becoming much more and more important in trials, showing that, and also there was improvements in delivery radiation. So I'm just going to step back a little bit, because as I keep talking about tumor biology, as Dr. Lopa had also, mentioned, the anxiety and the sort of the confusion comes with tumor biology. And it's really our job to explain to the patients that, again, it's not necessarily just about surgery or just about chemotherapy or endocrine therapy. A lot of it is dictated by tumor biology that tells us what is the best treatment modality. And so when we talk about tumor biology, I'm going to just show you here, this is actually a little diagram that I have drawn, and I actually use this to show to my patients. So when we talk about breast cancer, there's various subtypes of breast cancer, with the most common being what we call invasive ductal breast cancer. And it accounts for about 80 to 85% of breast cancers. Then there's 10 to 15%, which are lobular cancers, which are essentially cancers originating from the glandular or breast milk producing units. So women will either come in with what's called ductal carcinoma in situ, or more or invasive ductal carcinoma. And there's, of course, in between various other subtypes that are less common. So when we have a pathologist look at it, what they're reporting is what is called the estrogen receptor status, progesterone receptor status, and the third protein on the surface of cancer cells that may or may not be present called HER2 or HER2, which is another growth factor. Now, estrogen and progesterone are the main hormones in all women. And if you look at actually normal duct cells, we all have estrogen receptors or proteins and progesterone receptors, which actually receive these hormones in order for normal breast functioning. Some breast cancers will retain those estrogen receptors and progesterone receptors, thereby being what is called an estrogen receptor positive breast cancer and progesterone receptor positive breast cancers. Others will get rid of it. And Dr. Park will talk a little bit more about what's called triple negative, meaning that estrogen is not driving the influence of the growth of that breast cancer. So why is all of this important? Again, it comes back to treatment. And so what I usually outline for my patients, as you can see in the bottom, is that I find it very easy to break down treatment into two broad categories. I break it down into what's called whole body treatment, not because we necessarily have any evidence that there's cancer anywhere outside of the breast or maybe the regional lymph nodes, but the goal for all of us as providers, as patients, is we want this to be a one-time deal, meaning that we don't want to see breast cancer come back in 6 months, 1 year, 10 years, 20 years, somewhere else in the body. And this is where the medical oncologists play a very significant role. If someone has an estrogen-driven tumor, they will ultimately be just having a discussion regarding anti-estrogen therapy more as a maintenance to reduce the risk of not only a local recurrence, but a recurrence outside of the breast. Chemotherapy may or may not be part of the treatment option. And this really, again, Dr. Park will talk a lot more about it. There are very specific subtypes and stages of breast cancer in which chemotherapy may benefit women. And, I make this a very important point because that's usually the trigger word. A lot of the patients, when they come to see me, that's the first question they want to know. What stages do I need chemotherapy? And again, it's important to realize that no, maybe not. It's not necessary. Many women with estrogen positive, progesterone positive, what's called HER2 negative breast cancer may not need chemotherapy, although that's not always the case. A lot of it depends on, are your nodes positive? And quite frankly, with now more targeted, more what we call genomic testing and so forth, even if you have a node positive, so breast cancer is in up to 1 or 2 lymph nodes, even with an estrogen positive tumor, you may not necessarily need chemotherapy because, again, we have multiple other what we call genomic testing in order to determine if chemotherapy is even necessary for you. HER2, again, is another sort of a growth protein that we see on the surface of breast cancer cells in some women. It accounts for about 10 to 15%, or even maybe slightly less. The HER2 positive breast cancer used to, really be heralded as the most aggressive one, sort of the breast cancer with the worst prognosis. But with targeted therapy, there's therapy against HER2 positivity that actually has significantly improved survival. And usually these targeted therapies are given in conjunction with chemotherapy. And is that, in fact, treatment for triple negative and HER2 therapy, especially when given in what we call a neoadjuvant fashion, meaning even prior to surgery, really can help what we call downstage, not only the lymph nodes in the armpit, make them negative potentially. It can make the size of the tumor much smaller. Or especially in the cases of triple negative and HER2 positive, we actually see a phenomenon, what's called a complete pathologic response. And so if a woman had come in initially where it looked like we may not be able to do a lumpectomy, a smaller breast surgery, with chemotherapy, it really can actually become a reality where, again, by the time they come around to getting surgery, there may be no evidence of breast cancer within the breast, and they're really a good candidate for doing breast conservation or lumpectomy. So that's whole body. Now, quickly, where I come in, local treatment. So what I tell patients, the goal of local treatment is trying to figure out the best way to remove the tumor. How do we get rid of the cancer? And what can we do to lower the risk of local recurrence? What can we do, what can we do so that cancer does not come back locally in that same breast, the chest wall, or the lymph nodes? So again, surgery, as I went back in terms of the history, there's usually 2 options: mastectomy with or without reconstruction versus lumpectomy or breast conservation. Key driving point is that mastectomy versus lumpectomy overall survival is equivalent. What is different is the risk of local recurrence. So when we do a mastectomy, clearly, as you can imagine, that's the most aggressive that we can be in order to drive down someone's risk of a local recurrence. It will never be zero. There's always a slight chance, but I say in 15 to 20 years, the chance of something coming back is about 3 to 4% after a mastectomy, so very low. With a lumpectomy, the risk of a local recurrence can actually be about 20% in that same time period. However, with delivery or adjuvant radiation therapy, that risk gets driven down to by 2/3, so by 60%. And then if you're estrogen driven or if you need chemotherapy, that risk is reduced by usually an additional 40 to 50%. So now we bring you back down to single digits without having to have a mastectomy. So that's a very key driving point for my patients who feel that they need a double mastectomy when they come. And that's not to say that there are certainly indications for a mastectomy. There are certainly indications for double mastectomy. And due to time constraints, I'm not going to go into so much detail, but a lot of that comes in with, genetic factors. Is this a genetically predisposed breast cancer where we do actually worry about someone's realistic risk of a second breast cancer, third breast cancer down the road? So this is just, I'm going to skip that one. So again, just in the interest of time, I went back to talk a little bit about the history of surgery. So there continues to be ongoing advances in surgery. And again, we know that neoadjuvant chemotherapy really improves survival, but again, it improves our surgical options. It decreases the size of the primary tumor. And in many cases, we actually can achieve a pathologic complete response, which really also has what we call prognostic benefits as well. I didn't really talk much about axillary management or management of the lymph nodes, but there's also been significant evolution in what we do for the lymph nodes. Back during the time of Halsted and even Dr. Bernard Fisher, it was removing all the lymph nodes, regardless of whether or not someone had what we call clinically positive nodes or negative nodes. It was felt that, again, surgery needed to be aggressive, remove or clean out the regional system. That multiple trials have shown us that there's no benefit. It comes with increased risk, such as lymphedema and so forth. And so now we do what's called sentinel node biopsy. This is a sampling of the first few lymph nodes. And we find that if the lymph nodes are negative, there was really no reason to have even gone back and removed any more lymph nodes. And even after chemotherapy, where initially we would remove all the lymph nodes, we're finding if you have a complete pathologic response, why remove the lymph nodes? And we're still pushing the envelopes. There's trials out of Mayo Clinic, MD Anderson, where we're actually even trialing not removing the lymph nodes, even if you have 1 to 2 lymph nodes, because again, chemotherapy, radiation probably play a much larger role than we think, or that we've thought in the past. There's definitely changes in how we do mastectomy. It used to go from, again, radical mastectomy to modified radical mastectomy to now, just what's called skin sparing mastectomy, where we preserve as much skin as possible, to more commonly now even nipple sparing mastectomy, where we can actually preserve the skin envelope, the nipple and the areola. And this is all really shown that there's no survival different. We're not increasing the chances of breast cancer coming back by sparing the nipple, by sparing the areola. And we've been able to do this because of very good reconstructive options that are out there for women. There's now even a push for oncoplastic surgery. So we can do larger lumpectomies and have our plastic surgeons really, do what's called symmetry surgery. And thankfully in the United States, insurance actually pays for a lot of this. So where are we going? So in fact, as we start de-escalating surgery because of how good everything else is, we're even now pushing the envelope even more. Do we even do surgery at all? There's trials that we're enrolling patients out of Duke, looking at what's called ductal carcinoma in situ. This is really, for all intensive purposes, more of a precancerous lesion, and very similar to men with prostate cancer. We don't run to do surgery all the time. So the question is why are we, just because we're detecting certain entities, why are we doing such aggressive surgery, radiation, oncologic management? And maybe we can wait and watch. Maybe we can employ medical therapy rather than just surgery, and so forth. So I'm going to skip that. So again, I was only given 10 to 15 minutes, so I will wrap it up. I just wanted to give sort of an overview of where we are. And this is just a picture to remind you, this was actually just taken a few days ago. And believe it or not, this is a very, very small portion of our multidisciplinary team that I'm very, very proud of to be a part of. So thank you.
Thank you so much, Dr. Deba. That was, I cannot even explain, such an amazing, wonderful talk. How you, such a comprehensive talk, and it will help our patients so much. And that's the purpose, not only our team group here, our esteemed audience who have come here, but it's going to go, in a long way. And the way you have from the genesis, I just loved it, gave the genesis of it, and then brought us to the current scenario, and where from mastectomy, how we are moving towards the lumpectomy. But so many factors are needed, like as you said, like the receptor status and grade, so many things we have to take into consideration. And you touch base with the hormone receptor positive and the HER2 expression. But we also have another group when all these three are not present, and we call it as triple negative breast cancer. And what we see is mostly in the younger populace, we are seeing a lot of triple negative. And even in our support group, we have many TNBC, and also like across, like when I do the one-on-one, I see a lot of TNBC in the younger population and even in the older cases. With that perspective, we are going to bring our next speaker, and we are so honored to have Dr. Baho Park, who is the Cornelius. Give me 1 second. Let me just pull up my. Sorry about that. For some reason, my this thing is yes. So that I pronounce correctly. So we have Dr. Baho Park, who is the Cornelius Abernathy Gregg Chair, Professor of Medicine, Vanderbilt University Medical Center. He's the Director of Precision Oncology, Deputy Director of the Vanderbilt-Ingram Cancer Center, USA. So we cannot be more proud to have you, Dr. Park, here. And thank you so much for your invaluable, I know how busy your schedule is. I know everyone's schedule over here, but you gave time for our audience today. And thank you so much, Dr. Park. We are looking forward. And we have in our forum now, TNBC, who would love to hear from you, because I mentioned about your talk today. I mentioned about Dr. Deba's talk. So we are really thankful that you are here. So over to you, Dr. Park.
I appreciate the introduction, Dr. Lopa, and I want to thank everyone for attending, and also for inviting me to give me the opportunity to share a little bit about some newer developments in triple negative breast cancer. Let me just share my screen real quick. So I'm also a Susan G. Komen Scholar, and so this was a slightly modified version of a talk that I was asked to give when in a virtual meeting. As you can well imagine, for the past 2 years, we've all been doing things virtually. I'm sorry, I don't know why. Oh, there we go. These are my disclosures. So I'm often asked the question of why we haven't cured metastatic disease yet. And I think the problem of breast cancer and cancer in general is really that we've come to appreciate that all cancers at their very heart are really diseases of DNA gone bad. And we are all composed of cells, and the cells that are composed of proteins, and the proteins are made up or actually are encoded by DNA. And so that's why we call DNA the blueprint of life. And when one thinks about how our cells divide and allow our bodies to grow, we have fail-safe mechanisms to ensure that every time a normal cell divides, the two daughter cells, if you will, are identical sibs. So the problem with cancer is that those safety mechanisms to ensure 100% fidelity are gone. And so when one cancer cell divides, it begets different clones, as we call them, or heterogeneity. And even though we can have a lot of drugs that can eradicate many of these different clones, by the time we get to metastasis, we have already at least 1 billion cells. And we no longer have enough drugs in our kind of armamentarium to really eradicate everything safely. Some of my colleagues make the jokes that, we could actually cure metastatic disease, but the problem is patients won't survive it. And so there is some truth in that. And what ends up happening is that we develop, or our patients will end up developing what we call a bottleneck, or a clonal bottleneck. And then what ends up happening is that this begets even more aggressive tumors because there's even more heterogeneity. And this is seen clinically all the time. In metastatic disease, first-line therapy tends to be the most effective. And if you use that same therapy in a patient who hadn't seen it in first line, but now a second line or even third line, it can work, but the duration of that actually ends up becoming much, much smaller. And so I kind of liken it to pruning a bush. You can trim it back down, but every time you do that, it will grow stronger in many of the branches. Now, despite what I just told you, we are making progress, and most of it is through research. As we already heard, there are different subcategories of breast cancer that clinically are mostly defined by the receptors. So estrogen and progesterone receptor are now kind of just thought of as one category of hormone receptor, or HR positive. And this is by far the most common type of breast cancer, as I think many of you know, is hormone receptor positive HER2 negative disease. But here are some of the new therapies that we have, mostly in the metastatic setting, but now also in some cases, early stage or curative setting. So PARP inhibitors were mentioned for BRCA1 and 2 mutations. If patients have a germline mutation in BRCA1 or 2, this predisposes them to breast and ovarian and other cancers, but now also allows them to have access to PARP inhibitors, which is, again, a boom from bench all the way to bedside. This synthetic lethality approach was discovered sometime in the 1990s and early 2000s. And here we are now, we can actually give patients for both early stage in a curative setting, as well as in metastatic patients, these classes of drugs, which are highly effective. We also now, for metastatic disease in this subtype, have a targeted therapy against a mutant oncogene called PIK3CA. And we also have immunotherapy, believe it or not, and I'll explain a little bit more on that for this group and really any type of cancer, breast or otherwise, if they have something called a high tumor mutation burden. And then finally, there's a lot of new excitement and new trials going on right now for classes of anti-estrogen drugs that we call SERMs and SERDs. So tamoxifen is a SERM, selective estrogen receptor modulator. Fulvestrant is a SERD, selective estrogen receptor downregulator. These historically have been used for breast cancer patients, but we now know that you can develop resistance because of estrogen receptor mutations, and these new classes of drugs appear to be able to overcome those mutant estrogen receptor proteins. HER2 positive disease is defined as having overexpression or amplification of this particular protein, which sits on the cell surface. And again, we have a lot of newer therapies. Many of you have heard of Herceptin and other drugs like Kadcyla, but we have a new drug that's similar to Herceptin in that it's the same, similar to Kadcyla, and that's the same Herceptin antibody, but has a very different chemistry in terms of how some of the chemotherapies are studied across the molecule. And this has really become a very important and powerful drug for patients who are refractory to most, if not all, HER2-directed therapies. More recently, we have a drug called tucatinib, which is a pill. We call it a small molecule inhibitor. And the buzz behind tucatinib really was the first drug to be shown to be effective in patients with brain metastasis that is HER2 positive. Again, I mentioned immunotherapy for high TMB. We probably will also use PARP inhibitors. It's not an approved indication yet, but again, BRCA2 patients can get HER2 positive disease and would be expected, in fact, to respond to PARP inhibitors if they are BRCA mutation positive. And then finally, triple negative breast cancer. The big buzz is that we now have immunotherapy use for breast cancer that is triple negative. They have to usually be tested for a protein called PD-L1 or programmed Dept ligand 1. PARP inhibitors were already mentioned, and we know that for triple negative breast cancers, a lot of those patients will be BRCA1 mutant. Immunotherapy, even if you do not have PD-L1 positivity for metastatic disease, can also be given if that patient, again, has high tumor mutation burden. Probably one of the most interesting molecules that we've come across and is now approved for triple negative breast cancer is another antibody, what we call drug conjugate. So like the Herceptin molecule that has chemotherapy studded on the antibody, sacituzumab govitecan is a similar type of strategy where the antibody attacks a protein on the cell surface called TROP2, and then it's also hooked up to a chemotherapy molecule. So we are making progress through research. Breast cancer and immunotherapy is something I want to touch upon because this has generally not been a tumor type that responds so well to immunotherapy. And the kind of prototype of cancers that really do respond well or can tended to be melanoma and certain subsets of lung cancer. The reason we don't try just giving everyone immunotherapy is because there are significant side effects that people develop. And the significant side effects are not just something that will come and go as soon as you stop the drug. They can be permanent and long-lasting. They also can, in fact, hasten death. And any one of us who are oncologists have seen this. Every time I'm back on the inpatient service, I seem to find some new, really horrific side effect. I've seen a patient go blind because of these immunotherapies. I've seen patients be neurologically locked in. What I mean by that is that patient can no longer move, but except for blinking her eyes. So this is not trivial stuff. And so we have to be very, very cautious and careful about who really is going to have a higher likelihood of benefit than not. A lot of this is dependent upon, when I said high tumor mutation burden, finding mutant PIK3CA, about sequencing of tumors. This is something that we could not do readily 15, 20 years ago. And now it's very easy to send off a patient's tumor as well as their blood to look for BRCA mutations, as well as other mutations in the tumor. And again, this has really had an impact on how we think about and treat breast cancer patients. So as I mentioned, tumor mutation burden, or TMB, may predict for response to immunotherapies. And what does that mean? I liken this to the lottery. So we all know, or as I was mentioning, that cancer is really a disease of DNA gone bad. And when cancer divides, it's imperfect. And so you end up having mutations and other genetic alterations in the resultant cells. But that, even though that allows cancers to evolve and grow and get stronger, it also presents opportunities as their Achilles heel. Because when one thinks about it, the mutations that occur in cancer are, for the large part, just in the cancer cell. Again, the exceptions to that are the heritable mutations like BRCA1 and 2. But what we now understand is that as those mutations keep evolving, there's an opportunity that any one or more of them can in fact look different than the patient's normal cells to the immune system. And so that's the kind of problem with the immune system in cancer. Cancer is a disease of ourself, and so our immune system is trained not to attack ourselves. But it turns out that if we look at how normal cells and also tumor cells and immune cells, in this case T cells, interact, there are a number of what we call handshakes or checkpoints. And there's probably about a dozen of these. And it was discovered that if you block these interactions with antibodies, either against, again, PD-L1 or PD-1 on the T cell, you can sometimes elicit an immune response. Now, shown here is the real problem. You need something that the T cell will recognize in the tumor cell that is different than normal. And that antigen, as we call it, usually will arise because the DNA mistakes in the cancer cell lead to a mistake in the protein, and it's now looking like it's foreign. But it turns out that doesn't happen that often. So if you have a lot of DNA mistakes, it's like playing the lottery, as I was getting to earlier. The more tickets you buy, the higher likelihood that you can win the lottery. And so the higher number of DNA mistakes that a tumor cell has, i.e. tumor mutation burden, the higher likelihood that you may actually get a response. So this was first actually shown by colleagues at Hopkins when I was there, that you could actually have a much higher rate of immune response to cancers that had a specific type of genetic instability, as we called it, that leads to a high tumor mutation burden. And now any cancer that has a high tumor mutation burden, defined as 10 or more, can get immunotherapy. So any solid tumor, can be breast cancer, lung cancer, et cetera. It doesn't matter, and it doesn't really rely upon having to stain for the PD-L1 marker. This is an example of a patient that I had who had lobular breast cancer that was metastatic. Lobular breast cancers are almost always hormone receptor positive, HER2 negative, and hers was as well. So she wouldn't necessarily qualify because she's not triple negative, but you can see here where she had this big metastasis in her psoas muscle and really had a remarkable response. In fact, went for about 18 months before she progressed and had just an amazing quality of life. Was telling me that she would be at work and nobody knew she had cancer and she felt great. So there are patients who, despite not having triple negative breast cancer, can get these immunotherapies and respond. And this was the FDA approval that led to that just about a couple of years ago. Now, focusing more on triple negative breast cancers again, there are now new indications for immunotherapy and triple negative breast cancer. And these are really kind of the seminal papers that have really led to these increased uses. As I mentioned earlier, a lot of us in medical oncology are a little bit hesitant because of the potential for side effects and toxicities, including death. But this was a study, I should have put this one first, in the Lancet, which really put on the map for triple negative breast cancers using an immunotherapy, again, an antibody against this PD-1, that led to improvements for patients with metastatic triple-negative breast cancer in the first-line setting. This was called the Keynote 355 trial or 355 trial, and this really showed a big benefit and a difference. Now, again, with some toxicity, and these were patients who, the patients who benefited had to have a certain level of PD-L1 staining in their tumor. So one can't actually get on this drug for triple-negative breast cancer unless one has a high TMB or has a score that we call the combined, it's not important what it is, but it's basically a level of staining of PD-L1. And when they did this study, probably only about 30-some% really actually had PD-L1 positivity. So there still leaves a lot of patients who are going to get chemotherapy as their first-line therapy for metastatic disease. On the other hand, when we look at the same drug for early triple-negative breast cancer, so this is in the curative paradigm, this was a neoadjuvant study followed by surgery and then getting more immunotherapy afterwards. This was also a positive study, and it didn't seem to rely upon the staining of this PD-L1 molecule. So this was just approved a few months ago, and this is now standard of care, or a standard of care for the treatment of higher stage triple-negative breast cancer, higher stage meaning like stage 2, stage 3. When one looks at the data here, node-negative patients didn't really seem to gain much benefit. So I think many of us are reserving this really for only the highest risk patients in early stage disease to see if we can cure more patients. Again, there were side effects associated with this, so this is not something that we want to give to everyone. And then finally, probably one of the most exciting developments for metastatic triple-negative breast cancer is with this drug that I mentioned earlier, sacituzumab govitecan, or sacituzumab. This was a big multi-center prospective randomized control phase 3 trial led by a colleague of mine, Geetha. This always makes me feel old because Geetha was a fellow when I was the associate program director of our fellowship training program at Hopkins. And he's just done amazing things in the field. He's now at Massachusetts General Hospital. To kind of delve deeper into this, sacituzumab, as I mentioned, is an antibody, and it's an antibody against an extracellular protein called TROP2. It turns out TROP2 is expressed on many cancer cells and epithelial cells in general. And in fact, it's expressed so often in triple-negative breast cancer that we don't stain for it. So unlike HER2 in breast cancer, where we have to look and stain because only about 15% of breast cancers are going to have HER2 positivity, it seems like the majority or the vast majority of triple-negative breast cancers express this TROP2 protein. So we don't actually have a test that we're using to say you should get sacituzumab in triple-negative breast cancer. The somewhat unique thing about sacituzumab compared to other types of what we call armed antibody drug conjugates is the fact that the chemotherapy here, this is called SM38. It's a form of irinotecan, which is a common chemotherapy, but there are multiple different molecules of the chemotherapy linked to a single molecule of the antibody. This presents a little bit more toxicity than some of the other earlier generations of armed antibody drug conjugates, such as Kadcyla, but it also makes it highly, highly effective. And part of the reason for that, we believe, is that these armed antibody drug conjugates don't work on the same type of mechanism as standard targeted therapies. What they're really doing is what we call a Trojan horse strategy. And what I mean by that is when an antibody binds to an extracellular protein, what generally happens is that whole molecule gets engulfed by the cancer cell and it's brought inside of the cancer cell. And what happens in the acidic environment within the cancer cell, it releases the chemotherapy and it makes it active and it blows up the cell inside and out. It also has what we call bystander effects, meaning that the surrounding cancer cells will also get destroyed. And so it's really a way to more precisely target chemotherapy to the cancer cell and the tumor in general. Now, because of that, once it explodes, because it gets activated, there is going to be more systemic toxicity or side effects. But relative to chemotherapy, it is really night and day. And so this is kind of the diagram here on the right, what I'm talking about. If this is your protein molecule, whether it's HER2 or TROP2, the antibody binds here and goes inside and then blows it up from the inside out. Now, the only thing I wanted to say about this before concluding is that sacituzumab has been studied in this seminal paper only in second and third line therapies. And getting back to what I said earlier, the immunotherapy is in first line. So the studies that our field are doing right now is, can we bring this to first line therapy? But they're doing it in a very targeted fashion, combining it with immunotherapy, combining it with PARP inhibitors for BRCA1 and BRCA2 patients. So this is something that leaves open the question, if this was given instead of chemotherapy as upfront metastatic disease, would we see even more improvements in survival for these patients with metastatic triple-negative breast cancer? That's something that we're working on with many other groups as well. But I think that most of us feel like this could be a very, very powerful drug and have huge impact for triple-negative breast cancer patients as first-line metastatic disease. There are also now studies incorporating sacituzumab into early-stage disease, as you can well imagine, to see if we can afford a higher cure rate for those patients who have triple-negative breast cancer that is stage 1, 2, or 3. So these are my conclusions. I hope I've convinced you that patients, in fact, are living longer with triple-negative breast cancer, and that's really attributed to better therapies developed through research. Although we still haven't cured most metastatic breast cancer patients, I am convinced we have cured a few. I think most of us in the medical oncology business have seen pretty miraculous results on certain patients who get certain therapies. We haven't exactly figured out how or why these so-called extreme responders respond as well as they do. But some of them get off their therapies despite having biopsy-proven metastatic disease and are actually still doing okay. That really gives me high enthusiasm that as we study those patients, as we study other patients, that we're going to figure out how to cure metastatic breast cancer. So really more to come. And I hope the next time we have a conference like this, we'll have even more exciting news in terms of newer therapies for triple-negative breast cancer and others. I just want to give acknowledgments to my lab, both past and present, as well as many collaborators at Hopkins and at Vanderbilt. And of course, always to our funding agencies, as well as philanthropic sources that have been so kind and generous to support our work over the last 20 years. Thank you very much.
Thank you so much, Dr. Park, and I'm sure everyone will be benefited because you brought all the new, whatever the new trials also, what actually approved also recently. That's very helpful. And another thing very important is what you brought up is different. Like, it's not just about TNBC getting similar treatment, right? There's so many things we have to take into account, and that's what I think is so important for our patients to understand and learn. And your presentation will be so helpful. And really, really, we really appreciate you today for being here. And I'm sure we will have some Q&A. I know your time is, very valuable, but please, if you can wait for a little bit, and after our health heroes speak, we may take questions from patients or anyone who would need more information about TNBC. That would be very helpful. Thank you so much. And this is recorded, so it will go to everyone. So whenever anyone is facing this situation, please go over Dr. Park and everyone else, other speakers' talks, and that will be very insightful for everyone. Thank you so much, Dr. Park. And
Great,
our next, thank you. So now we are going to, bring in two health heroes. And, as we always say, right, that it's not only about detection, about the treatment regimen, and about what happens, like the diagnosis, treatment management, but it's also about the survivorship, how this, all these women and men with the fighting breast cancer, any type of cancers, they are our heroes because they have gone through this. And, and the most effective, what I see is when the journey of our breast cancer survivors, when it's being presented, because at that point, it gives a huge, huge support and positivity to the patients. And that also helps with the because that motivation is needed, and that's what our health heroes do. And we have two amazing health heroes today, and then we will open up the session for Q&A. Our first health hero I would like to invite is Panna Bharali, who is a breast cancer survivor. She is the secretary of Pratishruti Cancer and Palliative Trust in Dibrugarh, India, who are doing amazing work too. So, Panna, over to you, and I can't wait to hear your journey. I met Panna Bharali in 2018 in Dibrugarh, and if you hear her story, you will be amazed. And she is what Dr. Park mentioned about TNBC. That's why I wanted to join together, because Panna is a TNBC survivor. So yes, over to you, Panna.
Thank you, Lopaba. At the very outset, I would like to thank Lopamudraba for giving me this opportunity to share my experience in this platform. I was diagnosed with breast cancer for the first time in 2015, but unfortunately, I have been very familiar to this word since 2001 because I have lost my mother and sister in ovarian cancer. But when I was first diagnosed with cancer, I was broken and I devastated by the thought, why me? But I was lucky to get immense support from my father and my mentor, Dr. Gogoi Baideo, and all the well-wishers who helped me to accept this bitter truth. I went to the Tata Memorial Hospital, Mumbai for my treatment, and I had 8 numbers of chemotherapy and 20 numbers of radiation. During my treatment at Tata Memorial Hospital, I also went for genetic testing as I had a doubt that my disease may be a genetic one, as both of my mom and the sister were died of cancer. Finally, it is a genetic one as per the report. Because my mother and the sister were died of ovarian cancer, and both ovarian and the breast cancer are interrelated, so I was in a high risk of ovarian cancer as per the genetic test. I advised to remove my ovaries to save my life, and I had to undergo a surgery to remove my ovary in 2016. After 6 months of treatment, I returned to my hometown Dibrugarh with a new life and also with a new feeling that we have to do something to bring an end and all the myths prevailing in our society regarding cancer. I was determined that I would change the thinking of the people that cancer means death. With this thought, my father led Dr. Heramba Kumar Bharali and my mentor, Dr. Gayatri Gogoi Baideo, Manjula Agarwala Baideo, and some other like-minded people, we decided to start an organization to work on cancer and create an awareness in the society, and thus Pratishruti Cancer and Palliative Trust was born in 2017. The main objective of our Pratishruti is to provide overall guidance, including physical, mental, social, spiritual, all the support to the patient and their families. During this time, I lost my father, but only because of the Pratishruti members, I still have the feeling of having a family. They embrace me with all the love, care, and support whenever and whatever I need. Gradually, our organization started leaving its limit not only Dibrugarh district but also other districts of Assam. On our second foundation day, we launched 2 helpline numbers to help the people, and also we started palliative home care project, and side by side we have been organizing cancer awareness and the screening camps in Dibrugarh and the nearby district. After that, in the year 2019, while during my regular checkup, I was again diagnosed with breast cancer of the opposite breast for the second time. I made myself ready for another battle. This time, my breast has to be removed, and again, through the process of operation, chemotherapy, and the radiation, I was able to overcome hold the situation with my positive and optimistic attitude and my love, care, and the support from my Pratishruti family members. From my own experience, I can say one thing, that cancer does not mean to death. In my case, cancer is not a curse for me. It's like a blessing for me. It changed my life in a positive way. I, I think we all cancer survivors have a great role to play, spreading awareness about cancer in our society so that people came out from the myths related cancer in the society. Our organization, Pratishruti, we determined to make people aware about the deadly disease, to make people able to have a scientific approach towards the cancer, and to make them believe that people can have another life in spite of cancer. Also, what we need a little awareness, a little sense in our attitude, and some love, compassion towards the cancer patient and their family. Lastly, I want to say that as we are organization, we continuously work to reduce the burden of cancer, which means by creating awareness and early diagnosis and support the patient to continue their treatment. Thank you once again. Thank you, Lupaba.
Thank you so much, Panna. And if you would come to the video mode, please, so that we all can see you, who you are. And at such a young age, you have gone through so much, and you are a fighter, a true fighter.
Thank you.
Really. I get goosebumps when I hear your story each time, Panna, and I cannot be more proud of you, honestly. You move me so much each time.
Thank you once again.
Thank you. So our next, so nothing to say more after hearing Panna's story. Triple negative breast cancer, two-time fighters. She's still on fighting, and she has conquered it again. So that's the inspiration, that's the motivation, I would say, should be for all our cancer fighters undergoing right now, that you can do it. If Panna can do it, you can do it too. So saying that, I would like to invite our next speaker, who is another health hero and amazing story. So Kiran Goreja Anand, she's a breast cancer survivor. She's RN CMC Ludhiana, India. She is the ex-head nurse of AI Mafrang Hospital, Abu Dhabi, and she is also the counselor for the Rajiv Gandhi Cancer Institute and Research. So over to you, Kiranji. We are sincerely waiting to hear from you.
Thank you, Dr. Lopa, giving me a chance to come here and speak something about myself. My story starts 9th of November, 1999. It's 22 years before. And I deducted myself while taking bath. I just noticed there's a small node beside my breast and down my axilla. And next day only I went for FNAC was done, and FNAC was doubtful. And then my doctors, Tuesday, next day, one day after only all my tests were done. And Wednesday I was there for frozen section, and frozen section was present, my CA present, positive. And then radical mastectomy was done left. And after that, since I knew I worked as a RN and I knew what is it, I was not at all in panic. I knew how the pains I'm going to bear and what is going to happen with me, and what will be the treatment, about chemotherapy and about radiation. I worked a lot in this wards. So I had no problem at all. I accepted. So my all treatment was finished. Took 1 year to be all right. 8 cycles of chemotherapy and 25 sittings of radiotherapy. So it took me 1 year to be all right. After that, this time it was okay. I was not shocked. I accepted it. I was not in a panic at all. But next, after 10 years, it was a shock for me when I had a reoccurrence. On the same side, left side, on the suture line, like a mosquito bite. I've been to a doctor. Doctor said, you wait for another 10 days. If it grows, we'll see to it. So it started growing in size. And then FNAC was done, it was positive. Again, it was removed and I had to go for the same treatment again, not radiotherapy, but only chemotherapy. 8 chemotherapy cycles were given. But this time I was shocked also. My immunity was low, age also 10 years increased. But still I was trying to cooperate. But acceptance was not there. I had many complications, like my platelets had gone low and many things happened. Anyway, I finished my treatment successfully. So till now, after this treatment, I advise everybody, I will suggest everybody, and I look after myself also, like be regular with the doctors, with the visits, and your test all, and whatever doctors they say, we should obey to keep ourselves healthy, like diet, exercise, and doctors like telling so many things. Today also I am on immune medicines because my age is already 70, I crossed. And my lungs also, I got my PET scan done and they found small dots in lungs also 3 years before. So they started me on immune medicine. They said they are so small, It cannot be removed. We cannot take biopsy and let it be there. And so every 6 months, I got my CT chest done, and then PET scan done. And finally, they found it's because of the radiation lesions. So I was also relieved. So far, 22 years been over. I'm, by the grace of God, I'm healthy. I'm looking after myself. I'm very cautious about my diet, exercise, and doctor's visits. And more important is there is another important thing I would like to add. One should not feel shy if there is something present with the breast, inverted nipples, like any discharge from the nipples or any changes in the nipples while taking bath. One can examine, and then this they should be reported immediately to the doctors. One should not delay feeling shy. It's a breast. How to tell somebody? Husband is there, children they are there, relatives are there. Any trustworthy person we can inform, and we can see the doctor immediately. Another thing, after the mastectomy, I have seen ladies walking around without prosthesis. So I think this prosthesis is also very important. If silicone is used, it will be equal size and weight of the normal breast. And otherwise, after few months or after few years, our other side, where the breast is present side, will be start bending, and we change our gait also. So to look normal, confident in the society, so we should use prosthesis also. I'm also using. So I'm all right. I help myself for everything. I feel blessed, and I pray to God. Let's bless God bless all of us. Anything else? Tell me if I have to tell you.
No, that's wonderful, Gourangie. And again, see, like 2 times survivor of, so that's incredible. Your story.
I'm also triple negative. I'm also triple negative otherwise.
Oh, okay. So you know, like Panna and you, and because I want, so that's, I didn't know about your TNBC situation, but good you mentioned this. So this kind of gives so much hope to our TNBC patients who kind of we always, that's what Dr. Park mentioned, we are still working on it. You know, when I was working on my in the lab with targeted therapy, immunotherapy, we were constantly focusing on, before I started BCH, and you know, I was constantly focusing on all of those technologies. But now, like with the TNBC, now my research is more epidemiology study, clinical data analysis, more at the grassroots that I'm trying to do. And on that also, since I'm doing more of it, I get to see that in different ethnic groups, you know, and even in the Indian population, we are seeing a lot of TNBC. So what can be the reasons, you know, so we are trying to work towards it too. But thank you so much. Salute to you. Family history is already, yes, absolutely.
Family cooperation is also very necessary. And my 2 daughters, actually, they looked after me so well. I just can't forget. I'm thankful to them. And I really bless them. They are very nice, really.
Absolutely. Yeah. You know, family support, the palliative care that Panna mentioned, that you mentioned, the family support. When we think of palliative care, we always, you know, the perception many times I see is the end stage care. That shouldn't be. Palliative means like it should be from the beginning, you know, any chronic diseases. So I'm so, you know, thankful that you both brought it up, because it's so important for our audience to know, especially in our country, in India, and also in many sectors, in many communities, even in the developed world. So thank you so much, Gourangie. Hats off to you, and more power to you, so that you carry on, you know, inspiring everyone. Thank you. We are honored to have you here. It's honored to have both the health heroes here.
I always say thankful to universe, blessed me, and I'm thankful to universe, really. They have given me life.
Yeah, absolutely. Absolutely. So saying that, thank you so much to all our esteemed speakers today. You have blessed us with such informative sessions, informative talks, and we can't be more grateful, because this is recorded session is going to go on in different sectors. And even when new patients reach out to us, we are going to provide all of the information. So that becomes very helpful. Now, we are going to, without further delay, because we have already crossed our time limit, but, you know, because this was so informative that everyone is still here. The audience are staying back. So we would like to open up for a Q&A question answer session. And I would request if anyone who has any questions about the hormone receptor status, the TNBC status, please speak up first, because so that, you know, we take the very important questions which are very much driven towards the patients. So kindly please unmute yourself and please pose your questions, because we have such amazing oncologists here, you know, Dr. Deba, Dr. Park. I mean, we are honored to have you both here, and we would, so it's a great opportunity for our forum. So kindly please unmute and pose your questions.
No, I'm happy. I'm happy, but I want to know, is this genetic? But in family far off, there is nobody suffering with cancer. And why only me? Nobody ever I heard in my family suffering, my mother-in-laws, or anybody. But as before somebody said, it is a genetic, her mother, sister, everybody had it. But in my family, nobody had it. But I don't know the reason why, how I got it. I worked, of course, in CA ward for a long time, but that may be the reason.
No, so I mean, and so that's a very good question. You know, so as you know, was already discussed previously about risk factors, you know, there are multiple risk factors. And, you know, the most clear way to say it is that as long as you have breast, that's the risk factor. And so statistics for the United States is actually that 1 in 8 women will get breast cancer. So it's actually much more common than we know. And not necessarily related to family history or, you know, things like that. So it's really truly multifactorial. There are a lot of reasons to get breast cancer. And I think Dr. Park had also mentioned that, you know, it's sort of mistakes in trying to fix a problem. Our body is inundated with mistakes daily. And if that doesn't get picked up and get fixed, and this is how cancer develops. And that's the simplest way to sort of say it. And you know, and I get that question a lot. Why me? It doesn't run in my family. I eat healthy. I do everything. But again, it's so multifactorial. And as long as a woman has 2 breasts, there you go. That's the risk factor. Breast cancer, you know, risk increases as we get older. So that in itself is a risk factor. Now, we specifically look at triple negative breast cancer. Yes, when women have a genetically predisposed breast cancer, there is a tendency for them to have triple negative breast cancer. So from an NCCN guideline standpoint, what we say is when women are diagnosed with breast cancer that's triple negative under the age of 60, they should undergo genetic testing. Because the other sort of important thing to remember about genetics is that someone in the family had to have started, right? It doesn't necessarily have to come from mother and father. You know, an individual may be the first person to have manifested that genetic mutation, and then subsequently that individual can continue to pass it on. So that's our sort of standard of care. If you have triple negative breast cancer under the age of 60, it is definitely worth getting genetic testing. And of course, there's other criteria for testing.
Thank you so much.
Thank you so much, Dr. Deba. So that was very informative. And also, like, it's only like 5 to 10% is genetically inherited. So 80 to 90% it can happen randomly, as Dr. Deba said, that is a multidisciplinary effect. So we never know, you know. So, but we have to do everything that is possible to the best of our capacity, like, you know, with the lifestyle, with the environment we live in, even the work environment. That also I've seen, like, many men with breast cancer, they were working in the atomic center and they kind of eventually. So those are the different things. Just be vigilant, you know, to everything that we are doing, we are eating. So those things also, so many times a lot of women told me that they did everything right, but why did they get it? So the answer is we do not know. It's the small bucket. And I think before we take yes, so Dr. Gogoi, is that you?
I'm Dr. Gayatri Gogoi from
Assam. Yes, Dr. Gayatri, yes, please go ahead.
Do you have any experience? What is the percentage of women who are triple negative after genetic testing? What is the percentage of gene positivity?
Sir, could you repeat the question? I couldn't hear it.
Are you getting my question?
Yeah, so if you can repeat your
yes.
question, Dr. Gayatri, Dr. Park is asking if you can repeat your question.
Yes, I can repeat it. According to the guidelines, you are testing triple negative cases below 60 years. What is the percentage of positivity in those cases? Evidence of hereditary cancer.
So if you look at older data, one might suggest it's maybe about 5–10% at best. But those also all had a lower panel of genes that were tested as well. Sometimes only BRCA1 and BRCA2 were the only two genes tested. Now that we're starting to test, sometimes upwards of 100 genes, we're finding more. And so some studies may be as high as 12–13%. The issue becomes, though, that we're not 100% sure what that means for relative risk, because not all of the genes and not even all the mutations within the genes infer the same risks of developing breast or other cancers. So the whole field has become very, very challenging knowing what is really the relative risk of an individual who has a given mutation in a given gene. And so that's kind of where we're still going to be learning a lot as we go forward. But I think if you look at actual BRCA1 patients who are usually the ones with triple negative breast cancer under the age of 60, probably most estimates will still be around that 5, maybe 10%, depending on the number.
Okay, great. Thank you so much.
Thank you, Dr. Gogoi, for the question. So I will take this question, which was posed by Ipshita earlier in the chat room before we go live again. When you explain, this was for after Dr. Deba's presentation. When you explained about the anti-estrogen therapy, what about the treatment line for women with menopausal symptoms? I think she's talking about the hormone replacement therapy, the HRT. Yes, Dr. Deba.
Right. So that's a great question. And when we do see women who are diagnosed with breast cancer, especially in postmenopausal state, few of them are actually on hormone replacement therapy. So sort of twofold. So one, there have already been studies that have shown, and these are older studies, that have shown that hormone replacement therapy does increase a woman's risk for breast cancer, and that risk is related to duration of treatment. So the longer you take hormone replacement therapy, the increased risk that you have for breast cancer. But what was also very interesting is that women who took it short term, even if it's up to 5 years, and stopped it, the risk of actually developing breast cancer did start to level off and become average again. So prior history of hormone replacement therapy, if it was limited, doesn't necessarily mean that your lifelong risk for breast cancer is much higher than average. So that's another important fact to remember. So women who are taking hormone replacement therapy, what I tell them is that, talk to your primary care doctor or the OB/GYN who's prescribing it. Because at the end of the day, lifestyle also matters, so some women will start hormone replacement therapy because they have significant debilitating symptoms related to menopause, to the point where it's getting in the way of, just normal daily life, severe hot flashes and so forth, severe mood disorders. And as a result, they get started on hormone replacement therapy. But what's really important, is to constantly reevaluate, meaning that talk to your doctor and say, okay, I've been on it for 6–7 months. Maybe it's time to wean off of it. Maybe we should gently come down it, because the mistake that I have seen is that some women will take hormone replacement therapy just forever. They'll take it, 1 year, 2 years, 5 years, because they don't question it again. And sometimes the doctor doesn't realize, oh yes, I have a patient that's been taking hormone replacement for 10 years. And yet the reality is maybe after a year, after 1.5 years, you don't necessarily need it anymore. You've gone past the phase of having significant symptoms. And if you were to take yourself off of it, you might find you're okay. If you decrease the dosing, you may find yourself okay. So again, it's a very important conversation to have with your doctor who's prescribing this, to say, when is it time to keep coming off of it? For those women who are diagnosed with breast cancer, we certainly have them talk to their primary care doctor to say, okay, we need to do whatever it is in a gentle way to come off of the hormone replacement therapy. One of my big interests is what's called integrative oncology, supportive oncology. And so, we have great integrative oncologists who actually help a lot of our patients who suffer from the side effects of coming off of hormone replacement therapy and also taking anti-estrogen therapy or adjuvant endocrine therapy, to say, this is an important part of your treatment. What can we do to modify it so that your lifestyle is okay? And we're looking at things like even acupuncture, Reiki therapy, meditation. There's a lot of things that are natural that, and some women might benefit from certain supplementation that can help counter the effects of what we consider as beneficial treatment for breast cancer as well. So.
Very, very informative, very nicely, presented and articulated, Dr. Deba, because this comes up in almost many sessions that I take, and kind of like, as you said, with the duration and all the other aspects we need to bring into the factor. Thank you so much, Dr. Deba. So before we take more live questions, I see two hands raised. One is Paul Chahal and one is Kamal. So Paul Chahal, would you like to go first, please? Over to you, Mr. Paul.
Yes, please. My question is to Mrs. Anand. She mentioned about the prothesis. In terms of, I know that back in India, there is not any insurance and all that. What kind of a cost factor does it actually add for the patients? And what is the maintenance from day to day? Maybe cleaning it or maintaining it or something of that nature prothesis involves. I hope I clarified my question.
Yeah, there is no need of cleaning this. This is sometime can be just take out from the water and keep it back in the bag. There is a special box comes for it in a shape. So just keep it. It will remain safe.
Yeah.
Once it is punctured, once it is punctured means it is gone. It is spoiled one. So we have to take care of it. If you keep it in that box you brought it, it will remain the same with temperature and clean, and it will be safe. Yeah. So there is no chance of getting it spoiled.
Yeah. My other part of the question, that since the patients will be actually paying it mostly from their own pockets, how much it adds to the...
It is from their own pocket, and in India, if we go to buy, it is around 8,000, 10,000.
Great, thanks.
Yeah.
And also, thank you so much, Mr. Paul, for asking this question, and thank you for answering, Gourangie. And I don't know if I saw Jayashree Ratan here from the Saisha Foundation, so we collaborate with them also. If you need, they make a very nice, beautiful woolen, with the wool, like the breast prosthesis. So, and they are actually working with, I forgot the name, but someone from the US whose template they're following. So and they provide it free of cost, and they ship it to their home also. So we have already posted the information in our support group. So anyone needing any help with the prosthesis, which is like not silicone based and others, but made with the wool, please reach out to me and I'll help you with that. And I'll connect you with the Saisha Foundation for sure. Yes, and I think we have another question from Kamal. Kamal, I'm not seeing you right now. Are you there? Kamal, is Kamal there? I think he or she raised their hand. Okay, I don't see Kamal who was in here. I think he or she left. So any other questions? And if you can please unmute yourself, or did we miss any question in the chat room? Please unmute and ask.
It's me, Dr. Lopa, that you're telling about the woolen covers. That is actually a good thing. In the summer, so it's okay, no problem. But in the winter, you feel it cold when you use it, when you keep it in the bra or in the packet. But that time you feel cold. So if the cover is woolen, it's very good. So it won't give you that feeling. Sometimes you feel coughing, your chest.
Yeah, I mean, it's totally yeah, sure.
Yeah, it is totally
personal choice.
Totally perfect to save you from the cold.
Yeah, no, that's why if you need it. So, and it's also your personal choice what you want to do. That's why it's basically a mutual, like a discussion and decision being made between you.
I request you to give me one. I will also like to have one.
Sure, absolutely. I'll connect you. Definitely.
Yeah. Thank you.
So any other, if someone does, okay, so we have a question in the chat room. So I will read it out. And I think this is more towards Dr. Park. If someone does turn out to be positive for a specific gene, example, BRCA1 or 2, does that mean it trickles down to the children, future generations with 100% certainty?
No, it's not 100%. The way genetics works is that we all get half of our DNA from mom and half of our DNA from dad. And so depending on who the carrier is in the family, if it's mom, there's a 50-50 chance that that it can be passed along to the children. So when we do identify someone who has a mutation, we do what's called cascade testing. And so blood relatives, which include the children, siblings, half-sibs, uncles, aunts, etc., will generally get tested for that specific mutation to determine whether or not that they've actually inherited that. And for the children, it is a 50-50 chance of being able to inherit that mutation or not, with some strange exceptions that are kind of very rare examples of biology.
Thank you, Dr. Park. And I hope, yes, Ritu, I think we have answered your questions. So it's always a 50-50% chance, and does the genetics play a role all the time? So if any other questions, please, we have Dr. Park here, who is an expert.
Just following up.
Yes.
Lupa, that's me for asking a question in Ritu's account. Just following up on that, Dr. Park, you mentioned you do testing with the kids or with siblings. Is that a standard practice? Like if we had, like does insurance cover it, or like how do we proceed with that? Because let's say I have two young daughters, right? So
yeah,
my wife has breast
usually
cancer.
In this country, with the kind of commercial entities that perform these testing, they're all now offering what we call cascade testing for free. One has to be a little bit cautious though, and we generally recommend that everyone talk with genetic counselors in terms of when they get testing, beforehand, afterwards, what does this mean? And then what is the kind of next plan or step for cascade testing of blood relatives? And one has to remember that usually when these companies offer this for free, they're only going to test the one gene that was found to be mutated in the patient. And that's the rationale, is that it's probably going to be exceedingly unlikely that the children or the SIBs would have a different gene. Not impossible. For those of us who have done this know that sometimes that can very rarely happen. But that's why doing this in the context of some sort of genetic counseling really makes a big difference, and has really become kind of our standard of care in our guidelines.
Thank you.
And I'm going to just add to that. So exactly, that's also our practice, is that our genetic counselors are the one who are going to guide that, because again, it's if someone is identified to have a specific genetic mutation, then you want your children or your siblings to be tested for that. What is important is age, meaning when should you get tested? Because I've interestingly run into issues where parents will get their very young children tested at the age 5, 6, 7, and it's happened twice, and they're holding on to that information without knowing what to do with that. And so honestly, genetic testing needs to be done when it's age appropriate, when you actually can do something with that information. So if someone's identified to have a genetic mutation, again, 50-50, right, that each child will potentially inherit that mutation. Our recommendation is usually do it when you can act on it. So early 20s is not a bad idea, because one, if you're identified to not have a genetic predisposition, well, there you go. You have the sense of relief. You don't have to worry so much in terms of surveillance. If you are identified to have a genetic predisposition in your early 20s, then we can start doing appropriate surveillance, what we call high-risk surveillance. So not necessarily have to surgically act on it, but rather than wait till age 40, we would start implementing a surveillance strategy with the hope that, in the event something were to be developed, it would be early detection until that particular individual is ready to move forward with any sort of more, I'd say, aggressive strategies. So age really does matter, because I have had 2 individuals who come in as 16-year-olds and 18-year-olds with a BRCA mutation, and they're not mature enough to deal with that information just yet. So.
Yeah, I hope, I'm sure, Prakash, I think questions answered very well by Dr. Deba and Dr.
Thank you.
Yeah, thank you so much to both our doctors here. I think we will take the question from Kamal now. Kamal, you are here. I see your hands raised. And then I also want to mention that is the knitted knockers that I was talking about, because Savita Rao is here when I mentioned about Saisha India. And of course, it's not with woolen, but it's made of out of cotton yarn to suit the Indian climatic condition. So I'll definitely, again, repost it in our group, so you can reach out to Saisha India and you can take it from there. Thank you so much, Savita, for answering the question. That's very helpful. Yes, over to you, Kamal. You can unmute yourself, please. Hello. We can't hear you, so probably, are you still there? I saw a hand raised by the name Kamal in there. So do you want to ask a question or you're good? Okay, probably it's a mistake, so all right. So do we have any other questions, or if we do not, then we can wrap it up and just give another few seconds. Yes, do you have a question? Yes, Kamal, do you have a question, please? Please go ahead.
Yeah, just wanted to ask, my mom, she is 67-year-old. She recently got diagnosed with TNBC. So what happened, we had started a treatment at Manipal, Goa. So initially that portion has been removed by the doctor. Then 2 chemo cycle has been given.
You are breaking up, Kamal. Would you like to, you are breaking up, Kamal. We can't hear you. Maybe if you. Yeah, it's the network problem. Do you want to write it down in the chat room to everyone so that, Dr. Deba and Dr. Park can help answer the question? Sorry about that, but it's a network problem probably he is having. Yeah, all right. So Sabita, would you like to say something? I think you wanted to speak about Saisha, right? If you're here, please go ahead, Sabita.
Yes, thank you, Lopa. I am very much here. Actually, I think Jayashree got dropped out.
Okay, no problem.
I am representing Saisha. I am one of the core team members of Saisha. And I just wanted to help you, remember that we are associated with Knitted Knockers USA. We make breast prostheses. They are hand woven in merchandised cotton yarn. It is totally a volunteer-based organization, and we are giving these prostheses for free for every mastectomy survivor. And it is filled with fiber, which is washable, and they can wear it. And for every single mastectomy, we give them a pair of knockers so that they can alternatively wash and wear it. And generally, when we are providing these knockers, this lasts for almost 18 months if it is, handled with care and hand washed and worn. Then they can use it on a regular basis, and the lifespan is around 18 months on an average. And we do replace it when they place an order once again. They can get in touch with us on saisha.india@gmail.com. I'm sure you have the contact details. Probably you can share it with your forum, so they will be free to get in touch with us.
Yeah, perfect. And also maybe you can put down the email address in our chat group here so that
I will put it.
Yes, so that everyone gets it immediately and we can.
Yes, I'll do that.
Sure.
Thank you. Thank you so much.
Thank you so much. Yeah, so a lot of times many people had asked me, like with breast cancer hub, how do you differentiate? And I always say that why do we have to differentiate? Can't we all work together? Because we are fighting for a bigger cause, the cause of cancer. And if someone is already doing something, it's always good to connect them with the resources, so that, because we don't want to replicate, because whatever is our expertise, we want to go from there. So that way we can help more and more people, and that's the mission and vision, right, we all are working for. So I think we have Kamal, probably if you would like to, I know you are here, but you can actually email me your question. My email address, I'm putting it out here, because it's lopa@breastcancerhub.org, because I know you are having network issues. So please email me your question. I will forward it to Dr. Deba and Dr. Park, and we can go from there, so that your questions will get answered for sure. And I will also try to take a look at it, but I'll forward it to both our panelists here. So thank you so much. And I think it's already, I know you all have patiently have waited, and thank you so much to the panelists for your patience to be here today to respond to our, participants who had the questions, and so diligently you have done that. So thank you so much. And before wrapping up, I would like to really, really thank everyone who came to listen to our panelists. You have taken the knowledge, and please share it in the network so that anyone needing any help, that is the bigger purpose, right? So that we can spread the word and we can help them to make an informed decision. Because when we are even with the screening, it starts from screening to the diagnosis to the treatment regimen. And anytime you need any support, of course, you can reach out to me and I'll try to do my best. And we also have support groups, where we are always there for each other. So please, please reach out and of course share within the network. I'm going to share the recorded session with everyone, whoever signed up, and please take it forward. That's the bigger purpose, and each one of us can play a role in that. So thank you so much to our panelists, to Dr. Park, Dr. Deba, Dr. Geetha, Dr. Gourangie, to Panna, to Gourangie, and for giving your invaluable time today with your thoughts and with your expertise. Our forum, everyone is so enriched. And saying that, I would like to, close our session today. And thanks to all our honored guests also who have come in and to listen to our speakers. Thank you so much.
Thank you so much. Thank you so much for your great effort.
Thank you.
Thank you.
Thank you. Thank you so much. Yeah, I can now close the session. Bye.